Good day and welcome everyone. My name is Aros May. I'm the technical advisor for the IBP Network, and it's my privilege and honor to welcome you to today's webinar. This webinar titled WHO Classification of Self-Care Interventions is co-hosted by us and organized by the World Health Organization. Today's agenda is going to have a number of presentations from experts from around the world, and then we'll have an opportunity to hear some reflections and learnings from WHO, the African Regional Office, from Dr. Leopold Racco. And we'll finish with some remarks from Dr. Lalesai, who will, if we have time, help us coordinate some questions and answers, and then offer some closing remarks for the webinar. We are very excited to welcome you, more than 200 people online right now, and about 1,000 who registered for this important webinar. I want to share with you very briefly on the screen the background of our speakers. These are very short bios because of space, but as you could imagine, they have a very impressive background, and we're very excited to have them with us here today. Before we begin, I just want to remind everyone that the webinar will be recorded, that you can submit your questions anytime using the questions box, and there are 5 handouts in the handout section. One, the copy of the presentation, the resources on self-care, the bios of our speakers, and other resources for your review. Please visit our website. You can see that on the screen, and with that, I will welcome our first speaker, Dr. Manjula Narasimhan. Manjula, over to you. If you could unmute yourself, Manjula.
That would be a good thing to do. Yes, thank you, Rajas. So hello, everyone. My name is Manjula Narasimhan. I work in the Department of Sexual and Reproductive Health and Research at WHO in Geneva, and I lead the development of the public policy guidance and tools related to self-care interventions for health and well-being. And before I start, I wanted to thank everyone who made today's webinar possible. As you just heard, we have a great number of registrants to the webinar, over 1,000. And so thank you to all our presenters today for their time and for their valuable insight. Thank you to others for always hosting these webinars in such a remarkable way, to Sarah Van Borick for filming, and for many thanks to all of you for joining us today. So welcome. The goal of today's webinar is to present the WHO classification of self-care interventions. And this classification is intended to support the implementation of WHO's guideline on self-care interventions, and therefore it takes a health systems approach, which is aligned with the principles and the framework that informed this guidance. So I'll present an overview of the classification document, and then we will then hear from the several experts who will share examples of uses of the classification. And as I just said, we will also hear from our colleague from our WHO regional office on the relevance and the contribution of the classification to the introduction and scale up of self-care interventions in selected countries. So next slide, please. So just a few words on terminology. This is a terminology that currently informs WHO's guidance and the classification document. So we are very well aware that self-care is not a new concept, and that many partners have been working in this field for decades. And we're also aware that individuals and communities have been practicing some form of self-care since the dawn of time. So what can be considered relatively new is the acknowledgement self-care is playing in the public health and the healthcare delivery space. Next slide, please. And so self-care interventions include, but it's not limited to, includes evidence-based information, medicines, diagnostics, products, technologies. Some of them can be used by the individuals by themselves without the support of a health worker or the health system, and others may require some form of support. And included within this word self-care, the broader term self-care, is a range of terms such as self-administration of contraception or insulin, self-testing for pregnancy or HIV, self-management of medical abortion or self-management of blood pressure, and so on. So not all the terms are listed here, but the slide is really intended to provide an indication of the array of terms that exists. And this range of terms is one of the reasons we developed a classification document, because self-care often means different things to different people and in different contexts. The next slide, please. And I mentioned earlier that the classification document is aligned with the WHO framework for the guideline, and then the guideline itself on self-care interventions, both of which you see on the slide. So the framework takes a people-centered approach. It acknowledges that people are accessing information, they're accessing services, they're accessing products, not only in health facilities, but increasingly outside of formal health spaces. And the framework acknowledges the critical importance of key principles such as gender equality, human rights, and also the need for a safe and supportive enabling environment that does not leave individuals and communities burdened by having to manage their health, but rather empowered with greater autonomy, greater agency to do so. And so the guideline that you also see on the slide, it includes evidence-based recommendations in areas such as sexual and reproductive health and rights, non-communicable diseases, HIV, other health areas. And it upholds three principles. One, in engaging people and communities to take an active role in their health and their health services. Two, in supporting integrated health services, which meet the needs of individuals and communities across their life course. And three, in promoting a people-centered, multi-sectoral policy and action to address the broader determinants of health. And these three aspects are the foundations of primary health care and universal health coverage. And indeed, self-care is often the first point of entry to reach these health goals. Next slide, please. So why a classification document on self-care interventions? So we realized early on during the development and implementation of the guideline that while there was an overwhelming support for a health system approach to introducing self-care interventions, there was a need to develop shared language. So this first iteration of the classification document, like the guideline and like the other tools, is really intended to be a living document. It will continue to evolve with the input we receive from you and from those who are using the document, but also from the growing, sort of rapidly expanding evidence base that we have around self-care. And the purpose of this document, therefore, is to promote an accessible and bridging language for a range of stakeholders that include researchers, policymakers, donors, health program managers. Next slide, please. And a little bit about the structure. So the interventions that we have in this document connect individual needs and rights for self-care and healthcare, both in their role as self-carers, people caring for themselves, or in their role as caregivers to others. And it connects with enabling actions from a health system perspective. So these could be enabling actions from health workers, health program managers, health policymakers, legislators, regulators. And the goal is to advance health, the right to health for all. So these four sort of sets of interventions are provided within a simple structure of tables to allow more efficient readability on what these interventions could be. So next slide. And to use this intervention, we started the development of the classification from the person's health need. So starting from what individuals might want with relation to their own health and their own self-care, and the possible health system challenge that they might face in not being able to be able to take that action. So it could be availability or accessibility of a product. So this need and this challenge is then linked to a range of specific self-care interventions and enabling health system actions, which we saw on the previous slide. So for instance, just as one example, the need for accurate reporting of health events, can be supported by a self-care intervention such as a home-based record for health and diagnostic data. And so this classification also outlines a range of settings, including health facilities, the home, digital platforms, where these self-care interventions can be accessed. And ultimately, the goal is to improve health outcomes, such as, improved self-efficacy, such as providing a more tailored approach to the health needs of individuals and communities. And I mean, the contribution of self-care is really an additional option to existing healthcare. And it really has the potential, and I think mentioned it in this presentation many times, to advance the right to health for all. And we really hope that this tool can catalyze some of that progress in advancing health goals. And I think the next slide is my last slide. Yes, and so here you'll see a list of WHO resources on self-care, and the development of these resources, really would not be possible without it's sort of invaluable input from experts around the world, many of the partners who are here on this webinar. And we really continue to welcome your feedback. These are living guidelines and living documents that will continue to grow based on input and feedback. And so just after my presentation, I'll put an email on the chat, and you're very welcome to email us and send us your input. And now I'm going to hand over to our wonderful presenters, Georgina, Austin, Gina, Casswell, Patricia, who will walk us through examples of how to use this classification, and then to Leopold, who will provide some reflections on examples from the Africa region. Thank you very much.
The classification document, it provides guidance and direction. It helps you think through, if this is like the challenge, then what are the interventions and actions possible? How can they be delivered? And then what outcomes can we expect if we deliver these actions and interventions? Hello, my name is Georgina Casswell, and I am Head of Programs at the Global Network of People Living with HIV. I'm based in Cape Town in South Africa. And in terms of my role within the health sector, it is in program management. An example of a health systems challenge that we're faced with at GMP Plus is low levels of health literacy and lack of accurate information. Over the past couple of years, we've been working on a project supported by UNICEF and UNITAID, and it's focused on the scale-up of point-of-care infant testing. And as part of this project, we consulted with networks of people living with HIV in Senegal and Malawi about their health needs, and that's where we learned that mothers, parents, caregivers really lacked the most basic of information around HIV testing, including HIV self-testing, as well as HIV treatment for themselves and their children. Many did not realize that there are actually treatment options available for babies and children, and that these treatment options are actually effective. So they were saying, if we cannot treat our children, then why bother to test them? And as a result, they were generally staying away from the health facilities, both for the care of their children, but also for their own care. So how can the classification document help to address this health system challenge? The classification document, it provides guidance and direction. It helps you think through, if this is like the challenge, then what are the interventions and actions possible? How can they be delivered? And then what outcomes can we expect if we deliver these actions and interventions? The document is quite simple. It's got tables in it. And this one particular table that as a program manager, it's really easy to make sense of it. And it helps you just see, okay, if this is the challenge, then what is it that you can do about it? Where can you address it? And then, what impact could it have? So if we follow the flow in the classification document, having identified the health system challenge, then the specific self-care interventions that speak to lack of information are interventions to promote awareness about self-care, improving health literacy to support health decision-making, and facilitating understanding, use, and uptake of self-care interventions as an additional choice to clinic-based care. And coming back then to my example, we implemented those 3 interventions to address this challenge. So we produced a range of tools, leaflets, posters, animations, discussion guides for group work, job aids for peer educators. And the idea was that these tools would be used to remind parents and caregivers of their options and what is possible also for their children. So to really help parents and caregivers make decisions about their own health and to equip them with the skills that they need to have the self-confidence to know that there are things that they can do for their own health and for that of their children. We addressed the issue of the right to services. We also looked at testing, including self-testing for mothers, fathers, and caregivers. Another topic that was really important was breastfeeding and mothers wanting to know what were the options for them, and also the issue of HIV treatment. Stigma was a really important topic where parents and caregivers had questions, as well as practical tips and ways to reduce the chances of getting COVID. So all of these were topics that mothers, fathers, caregivers themselves raised as questions, and we actually co-created these materials with potential users from the networks of people living with HIV in Senegal and Malawi. They would receive this information at health facilities and also digitally. We heard from them that it was actually really important to them to be able to discuss things during community group sessions and peer-to-peer sessions. And the materials are available in English and in French on the GMP Plus website. The outcomes we're hoping to see in our example is better informed, self-confident individuals who know their choices and have the skills to negotiate and make decisions. With greater knowledge, with greater power and agency, this would then impact on their access to testing, including self-testing, uptake of HIV treatment, and adherence to medication. And ultimately, it will improve the health and the quality of life of individuals and those they are caring for.
The financial and social return on investment potential of self-care is huge, and the classification of self-care interventions is helping various actors, self-carers and caregivers, health workers, program managers, policymakers, legislators and regulators with a common language to articulate how self-care interventions can be implemented at scale. My name is Oster. I'm Director of the Self-Care Academic Research Unit at Imperial College London. In this role, I'm routinely involved in research, training, and education. In my other role as General Manager of the Director of Public Health and Primary Care at Imperial College Healthcare Trust, I'm also supporting the Pan-London evaluation of the BP at Home initiative, which I'll discuss shortly. So in my role as a health program manager, I'm working as part of a team to streamline the adoption of a task shifting model to promote self-care in people with high blood pressure. The BP at Home initiative is one component of the NHS at Home program, which aims to provide better connected, more personalized care in people's homes. This nationally led program aims to ensure people have faster access to more appropriate and targeted care without having to attend unnecessary GP appointments. This task shifting will help address the current shortage of healthcare workers as the health system is under tremendous pressure, and not just because of COVID, but even preceding that, because of the rising epidemic of non-communicable diseases such as type 2 diabetes, obesity, and cardiovascular disease, and some types of cancer that are putting huge pressure on people and health systems. So for the case study, I'll briefly introduce the BP at Home program. In the UK, there are 8 million hypertensives, and each of these patients require routine monitoring to help them regulate their blood pressure. NHS England bought 220,000 blood pressure monitors that they could give away to people to help them measure and control their blood pressure in the home setting. This is an important initiative because there's an insufficient number of accessible health facilities, especially since the advent of COVID. In terms of how we could use the classification system, well, there are individual health needs and self-care related health system challenges that we need to address. For example, to promote agency, to ensure that people can actually use these devices in self-care in the home setting, and of course, to tackle the accessibility issue, to make sure that we provide a service to underserved populations and ensure that we address the lack of access or limited service to certain populations and the accessibility issue in general. So the document describes how each health system challenge can be addressed by considering three components: the class of self-care interventions and the enabling actions for that, the modes of delivery and places of access, and the anticipated improvements in health and well-being outcomes that we expect to achieve. In the case of BP at Home, the self-care interventions and enabling actions that could be implemented are really concerned with self-testing, including to inform prevention, self-care for long-term health conditions, in this case hypertension, providing training for the rational delegation of tasks to lay people, and developing and promoting access points to self-care interventions for self-care users and communities. In terms of modes of delivery and places of access, we're really talking about using digital technologies and platforms to streamline and promote home-based care in a way that is congruent and effective. So in this case, patients are onboarded, they are supported with onboarding information, links to videos, and shown how to use a blood pressure monitor. They're invited to do regular monitoring of blood pressure at home, and then to communicate the blood pressure reading to their general practitioner or physician using an app. So there are many skills here that the patient would need to know, and also the healthcare professionals need to know to ensure that the self-care intervention actually completes the virtuous cycle. In terms of the potential outcomes of applying these self-care interventions, the health system can benefit by improving the agency of hypertensive patients in this case, and also addressing a key accessibility issue. And this is done obviously by making these devices more accessible and improving people-centered approaches, and also helping people monitor and control their hypertension in the home setting. The financial and social return on investment potential of self-care is huge, and the classification of self-care interventions is helping various actors, self-carers and caregivers, health workers, program managers, and policymakers, legislators, and regulators with a common language to articulate how self-care interventions can be implemented at scale.
For me, as a researcher, as a health planner, as a policy advisor, the classification document is really helpful. It allows us to start to think about metrics for measuring and evaluating. So when you have a shared language, you can say, I'm interested in measuring, monitoring, evaluating X, and you can do that. Good afternoon. My name is Gina Ogilvy, and I'm a professor in the School of Population and Public Health at the University of British Columbia and a Canada Research Chair in Global Control of HPV-related diseases and cancer. So I work both from the research side, but helping to advise policy, particularly around cervical cancer elimination, with a focus a lot on vaccination, but also on improving screening coverage, which includes things such as self-collection for HPV. When I think of real world system challenges that I'm dealing and I'm facing, it's really about the access to cervical cancer screening. So we've had for years relied on Pap smears, and that requires a woman to go to a health practitioner and to undergo a Pap smear. And so that requires them to leave home and to leave work and to perhaps bring children with them when they have to undergo this important health screening. One of the opportunities as we move in my field from PAPs to HPV testing is actually that women can actually self-collect or gather the screening themselves. So we call that HPV self-collection. And so when we think about self-care, what this really addresses is accessibility and really the lack of access or limited service for certain populations. And in Canada, where I work, and also in low and middle income settings where I also work, this is particularly for folks who don't have access to healthcare in general, but also for rural and remote areas, which may have limited health practitioners. For me, as a researcher, as a health planner, as a policy advisor, the classification document is really helpful. Because first of all, when I'm doing my research applications and research grants, I can have a shared language with the reviewers, with other sort of colleagues, co-investigators. So that's the first thing, is having this shared language. Second, it allows us to start to think about metrics for measuring and evaluating. So when you have a shared language, you can say, I'm interested in measuring, monitoring, evaluating X, and you can do that. So for instance, in my setting and in the things I'm interested in, I can look at coverage and uptake of self-care, and I can speak the same language across policy, across research, across clinicians. The self-care interventions that I'm working on are HPV self-collection to really improve the coverage and breadth of cervical cancer screening, both in high and low income countries. So when I look at the classification document, it speaks particularly to self-care interventions related to external testing. It allows for peer-to-peer action to support access and use and uptake of self-care interventions. And it also would allow development of programs and implementation tools that allow us to then tailor self-care intervention services, both to individuals' needs, values, and preferences, but also to community and regional needs, values, and preferences. So self-care and self-collection for HPV has a variety of modes of delivery in places where you could access. One of the opportunities with self-collection is it can actually be done at home. So that's a very exciting opportunity because women are busy. They've got lots of needs in terms of their family, in terms of work, in terms of community. So to allow them to collect at home and then have the specimen sent to lab is a real opportunity. However, self-collection can also be done at health facilities. And that's because when women show up to attend another healthcare encounter, say it's even for a child, they would be able to, at that time, quickly provide a self-collection and allow them to receive screening in that health facility as well. One of the most exciting things about self-collection for HPV is it's really going to be able to broadly increase cervical cancer screening around the world. It increases accessibility. It increases approaches where people are at the center of their healthcare and they actually make their own choices for healthcare and they actually have control of their healthcare. It can be a foundation for gender equality because, of course, we know in order to have equality, we need to have women be healthy and we need to make sure they access care to help them be healthy. It can also improve health promotion because it doesn't just have to be a practitioner in a healthcare setting or in a hospital who offers a test. This can be village health workers, it can be local health community leaders who can offer and recommend for women to get screening. And ultimately, it does allow improved access to resources and support for an individual's health problem. So for instance, if they require further follow-up, the access to self-care allows them to get along that pathway to improve ultimately their health outcomes and ultimately prevent cervical cancer. The world has the opportunity to eliminate cervical cancer, and every year over 500,000 women develop this cancer and 300,000 die from this entirely preventable cancer. One of our key challenges has been coverage and getting women access to screening. And this important self-care intervention of HPV self-collection will allow us to broadly improve screening coverage and then allow us ultimately to target women who need follow-up and treatment for both cancer, but also for precancerous lesions, thus preventing the development of cervical cancer. So this self-care intervention can actually have a transformative effect on women's health globally. And it's a really exciting time as we put healthcare in the hands of women and allow them to ultimately improve their own health.
Especially in the developing countries, availability of services in the health facilities is very limited. WHO classifications in the framework is extremely helpful. Through this, we could achieve universal health coverage, and we could also address the issues of equity. I'm Kausar Afsana. I've been doing research and I'm trying to influence the policymakers, especially for data for decision making and also for implementation. But I actually had 3 decades of experience. So I worked also in interventions, especially in designing and implementing interventions, and also in the strategic positions and for policy influencing in my earlier career. According to the WHO classification, the way that framework is laid out, one is, of course, firstly, the health system challenges. What is the health system challenges? Especially in the developing countries, strained health workforce. It's a huge a problem. And in the context of Bangladesh, at this moment, we do have only 3 physicians per 10,000 populations and 1 nurse for 10,000 populations. So can you imagine availability of services in the health facilities is very limited. That means that especially the disadvantaged population, the women, the poor, and the marginalized population are suffering a lot. The hard to reach areas, the rural areas are very much deprived. So Bangladesh government is addressing this issue, having the frontline workers to be trained and to provide services. They are from the community, so that means they live very close by to the populations. So accessibility of the services is much better. So what are the interventions actually we need to take? We facilitate for the understanding, for the uptake of the self-care interventions, in addition to using that clinical care. We are task shifting and task sharing this from the skilled workforce to frontline health workers. That means they need to be more trained in terms of communications, in terms of how to maintain the dignity, the self-esteem of the women, and also the stigma, discrimination. That kind of training actually need to be packaged, and it's very critical in terms of creating an enabling environment for the women or the disadvantaged population to seek health services. In WHO classifications, so third step is how you could also provide. That means the mode of delivery. So mode of delivery could be at home. The mode of could be using the digital solution. Mode of delivery could be the nearest health facility, and mode of delivery could be pharmacy. Now, if I could give you an example from my own country, that especially Bangladesh is very successful in family planning program, and over the years we have seen that how family planning uptake has gone up in this country, which is quite traditional and conventional. Community health workers or frontline workers are going house to house, meeting with women, and this is very helpful for the women, not only for the awareness perspective, also for better communications, better understanding of the information that why we need a family planning. And our total fertility has gone down from 6.5 to 2 almost. That means going to the replacement level, and oral contraceptive and injection is actually about 40%, which was 8% 30-40 years back. So that means it's a huge change. According to that WHO classification, the framework, the way it is laid out, the last one is the improved health and well-being achieved, and especially with self-care interventions. It speaks about that how could you improve the increased availability of services, and how could you also improve the respect for an autonomy of the individuals, and apart from that, how could you improve individuals' access to resources and for their support and for the better health out management. The way it is designed, it's actually is a people-centered approach, and respect, confidentiality, and health priorities, preferences, and more important is the respect and dignity for the individuals who are seeking these services. WHO classifications and the framework is extremely helpful for not only for the policymakers, the planners, the program people, even for the community people, that if you do understand the researchers, it's really helpful tool. Through this, we could achieve universal health coverage. And universal health coverage is one of the critical part of self-care in SRHR interventions. And we could also address the issues of equity.
We're saying people can also take care of their health. To understand this new paradigm, I think a tool like this classification of self-care interventions is going to be very helpful. Health policy managers and regulators can find there how to really move the whole health system into this new era. Hello, my name is Patty Garcia. I'm a professor at the School of Public Health at Cayetano Heredia University in Lima, Peru. I'm right now in academia, but I have been the head of the National Institute of Health and the former Minister of Health of Peru. So I had the chance to work in research, academia, and also at the government. And today I would like to talk about health policy managers, legislators, and regulators, and the role on self-care interventions for health. Health issues in this 21st century are complex for the whole world. Finally, we have recognized that globally we share vulnerabilities. Populations are growing, are getting older, and that is causing demographic changes. We have the epidemiological transition that is bringing infectious diseases plus non-communicable diseases, creating a double burden of diseases. We have climate change, humanitarian crisis, civil conflicts, and that is bringing also another problem, the burden of mental health, which is a major public health problem. Everything in an interconnected world where people are traveling and information is traveling even faster. And that is causing a lot of social pressure and technological pressure. And so the challenge is how can we adapt health systems to promote prevention and ensure access and care? And one of the ways in which we can really work on this adaptation is by using new things. One of these innovations is the use of self-care interventions. Self-care interventions are critical to address health systems' critical challenges. And let me give you a real example, an actual example. During the pandemic, testing has been a critical component to identify cases, provide care, and reduce transmission. However, health centers had been overloaded with people seeking to get tests and also with people that needed care. COVID-19 antigenic tests became available and offered the possibility of self-testing, but due to existing regulations, over-the-counter products for self-testing had not been allowed in several countries. One of them has been my country, Peru. However, we know that people knows about diagnostics and they feel really capable of doing their own testings. Surveys in Peru regarding the use of diagnostics have found that most participants would use home tests. And they said that they could use it for determining the health status of the child, as a diagnostic aid for health issues during pregnancy. And recently, they feel comfortable if they could have something in their hands to see if they are having COVID or not. The only thing is that they only want to have good operations instructions from the manufacturer and later guidance of what to do with the results. Moreover, women and men are willing to pay out of pocket for these OTC diagnostics. And in the case of COVID, people would prefer a test that is much easier to do, of course, a saliva test instead of a nasal or pharyngeal swab. So what happened in Peru? In view of this demand, the DGMIT, which is a regulatory agency for drugs and medical devices, which includes also in vitro diagnostics in Peru, they decided to review, revise, and reformulate and adapt the health policy so they could incorporate these self-COVID tests. And they just recently approved the availability of COVID-19 self-tests over the counter at pharmacies. That has promoted autonomy, saving time and reducing risks. In the case of the COVID tests, we still have issues regarding availability, so we have to be sure that we have the tests at the pharmacies. Affordability, they shouldn't be expensive. There has to be some type of control so people could have it. The quality of the tests is another thing, the follow-up, the referral that people are asking, and the reporting of results. So with self-care interventions, there are some critical issues. They should be tailored around users, they should be validated, and there should be links to the formal health system, especially for those that are positive for referral and management. But we have to understand also that there are barriers. We still have problems about acceptance of the results by the formal health system. There could be economical interests because there could be competition with paid services. So there has to be some type of regulation. And using self-care interventions means that we're changing the power of dynamics between those that provide the care and those that are asking for the care, the public. So these are issues that need to be addressed and need to be discussed by regulators and also by health policy managers. Self-care interventions can increase coverage, can decrease disparities, can empower community members, and can decrease the overload of health centers, letting more time for those individuals that need further care. And the other thing that is quite important, they are very much accepted by community members. We are used to do most of the care related to health at health centers. And what we're doing right now is we are changing this paradigm. We're saying people can also take care of their health, and that is self-care. And because it's kind of complicated, okay, to understand this new paradigm, I think a tool like this classification of self-care interventions is going to be very, very helpful. Health policy managers and regulators can find there not only what are the different types of self-care interventions, but also examples of the kind of things that they can start doing to help the introduction of these self-care interventions and how to really move the whole health system into this new era in which we are working together, communities and health providers, to change the health of people.
Well, thank you very much to our presenters. And I'm going to now introduce Dr. Leopold Racco, who is the Regional Advisor for Sexual and Reproductive Health at the WHO Africa Region Office. Go ahead, Leopold.
Okay, thank you, Ados. Just to say that with the 2021 WHO guidelines on self-care interventions are being implemented in several countries within the African region, and just talk about the perspective regarding the WHO classification of self-care interventions. Slide. And this we have done. Working jointly with WHO headquarters, a series of dissemination meetings, some orientation, including with other partners. And we have seen a strong interest from countries and implementing partners for rolling out these self-care interventions, taking into account, of course, also the COVID-19 pandemic. And we can see that in many countries, WHO guidelines on self-care interventions have been disseminated, and work is really in progress around scaling up such approaches. And in this context, we really believe that the classification document is a kind of resource that will align people's understanding and needs, will allow people to talk the same language, and will simplify the use of self-care guidelines. And the classification of the self-care interventions can really support the national implementation of the guidelines by creating a common understanding among key stakeholders. So for this reason, we really welcome the classification of self-care interventions. Next. And as I already mentioned, we are supporting a number of countries within the region to implement the self-care intervention for sexual and reproductive health and rights. And for example, we are working more intensely with headquarters colleagues to support 5 priority countries within the region to scale up the implementation of the self-care interventions for sexual and reproductive health and rights. And below are some examples of the use of the classification document. In Burkina Faso, for example, we are using currently the classification document to support the implementation research on introducing the DMPA subcutaneous self-injection. In Ethiopia, we are supporting the country to develop national guidelines on self-care interventions, and the classification will be really useful for that. In Kenya also, the classification can allow for better articulating the sexual and reproductive health and right needs of women and girls based on identified health systems challenges. In Nigeria also, WHO and partners are currently supporting national inventories and landscape analysis for self-care interventions, and the classification will surely allow for supporting policy dialogue around introduction and uptake of self-care interventions. And lastly, in Uganda, promoting advocacy and communication around what we mean by self-care more broadly, and what we mean by self-care for sexual and reproductive health and rights. This is something that is ongoing, and the classification will really support this advocacy and policy dialogue. So these are the 5 priority countries we are jointly supporting to speed up the implementation of self-care interventions, but there are other countries that are in the movement and trying to implement also the self-care intervention. Next slide. We can see this is just a rapid assessment in some countries, and we can see that many of them are implementing self-care interventions at various levels. Most of countries are already implementing the self-provision of contraceptive pills. Quite a number are already back in the DMPA subcutaneous self-injection, and others also are implementing the self-management of abortion, and some are doing the HPV self-sampling, the self-sampling for STIs, and also the HIV self-testing. So a range of self-care interventions that are being implemented in many African countries, and we do believe that the classification will be really useful, and it will improve the understanding facilitate implementation at scale of playing within the actors and also fast of the self-care interventions. Next slide. So lastly, in fact, yes, just to also add, one of the key added value of a classification is related to the development, the implementation of the smart guidelines. And we already know that W2 has published recently the digital adaptation kits for antenatal care and family planning that include aspects of self-care interventions. And now we are working on the first volume of the self-care digital adaptation kit to support digital home-based records. And the classification on this context will also, again, serve as a resource to ensure that we are all on the same page. So these are really what we want to share with you regarding the added value, the importance of the classification in the uptake and implementation of the self-care interventions within the African region. Thank you, and over.
Thank you very much, Leopold. And I want to ask Manjula, are you back in line?
Yes, I'm here, and I wanted to introduce Lale. You know, we heard back from all these presenters on examples of, you know, what's been happening with self-care interventions in many contexts, and handing over to Lale now for some final thoughts, but also some to maybe field some questions if there are any from the audience. Lale, over to you.
Thank you very much, Manjula, and thank you very much, Edos. Before a few closing remarks, I wanted to check if there are any questions. I'm looking at the chat box. I think there are examples, similar examples to what we have also heard from the audience, and that's great to see. In the audience, we have some experience on implementation of self-care in different areas. Edos, were you able to receive any other questions that we can, before closing, we can check any burning questions? Probably not. Maybe I should ask one question before closing to Manjula, and thank you, Manjula, for your initial presentation. And of course, we have seen excellent examples of from the real world, from these different aspects of self-care interventions. And maybe apart from these excellent examples, how you would lead in use of the classification document or further dissemination of classification document to ensure that is being benefited by the people who are needing that.
Thank you, Lale. So yes, that's a good question. You know, we published this the classification document in December, so it's been quite recent, and you know, we often work through our regional offices and our country offices to disseminate. But I think in this case, we also have we have a number of partners, including the self-care trailblazer groups and other partners who have been very supportive of the advocacy and the communication around these documents. So we're hoping that there are many channels that we can explore, and that we can continue to receive feedback so that we can amend the tool as we move forward.
Okay, thank you very much. So one perhaps notice to all our participants is really, if you have any feedback or any comments on the use of the classification document, please get in touch with us so that we can continuously improve the document and document its use. I really would like to thank so much to all our participants, presenters, who have provided excellent real-world examples from different aspects of self-care interventions that are very much needed to improve access to care for those who are actually needing this care. And also very concrete examples of how classification document can be used to facilitate the use of the self-care interventions, or in line with WHO's guideline. So we are very happy to see these examples, and looking forward to working with everyone, with our partners, with our colleagues, and all program implementers to help moving this area forward, and looking forward to our future engagements. Thank you very much also for Manjula in leading this work in WHO, and Edos, thank you very much for the organization of this great webinar. Have a good afternoon and evening and morning, everyone.